Gail Demko is our new president-elect and will be president beginning next year, next summer. Dr. Demko received her DMD from Boston University. She's an expert to the FDA on oral device therapy for sleep apnea and a recipient of the AADSM Distinguished Service Award. So she will become president of the AADSM at the 2012 meeting. I know she'll be an excellent leader, and I look forward to collaborating with her much more over the next year. Okay?
Thank you, Sherry.
Okay, so anyway, I really want you to pay attention to this next project, because this is in light of all the tough stuff we've been going through. Gail has done some amazing work that's really fun, and she's about to share it with us.
Thank you. And thank you all for coming and making this meeting as special as it is. Oral appliance therapy for obstructive sleep apnea has become an important part of the sleep medicine field. And in the last 20 years, the literature reports on this topic, and you know how I am about literature reports and proper citations, has becoming increasingly, we've gone from 4 articles in 1989 to over almost 200 articles now just in oral device therapy in the literature. The majority of the articles discussing the history of dental sleep medicine cite an article from 1934 by Dr. Pierre Robin as the earliest report of this treatment. Others incorrectly cite an article that was never written as in 1902. The 1934 article, Glossoptosis due to atresia and hypertrophy of the mandible, does not itself discuss sleep apnea, but serves as a secondary reference because in this article he said, as I said in my 1923 article. Now, the 1934 article is the only article Pierre Robin ever wrote in English. He didn't. It was translated into English and published in an American journal and actually discussed the feeding of cleft palate babies. But he did mention the 1923 article, which means I could go to the Harvard Library where no one could stop me as I took this article and threw it on the Xerox machine. I then asked my sister Raleigh, who is here with me, who's a French teacher, to help me translate it because my French was rusty at best. Robin cites the original article as the therapy of patients of retrognathia and failure to thrive. And this isn't just failure to thrive babies, but failure to thrive adults also. The citation for this paper, also by Robin, published in French in January 2nd, 1923, issue of the Bulletin of the Academy of Medicine, is entitled Relapse at the Base of the Tongue, considered as a new cause of nasopharyngeal respiratory problems. It describes the use of a monoblock oral appliance that he had developed in 1902. So Pierre Robin was a physician and a dentist in Paris who coined the term glossoptosis, used now frequently in our field, and defined the relapse of the tongue secondary to retrognathia or micrognathia. Born in 1867, he was an editor of the Revue de Stomatologie in Paris and active on the staff of the Children's Hospital in Paris most of his professional life. In 1902, he first told his peers about his use of an oral appliance to treat adolescents with micrognathia to improve sleeping and eating. He later went on to study various syndromal abnormalities, one of which bears his name today, the Pierre Robin sequence. He died in 1950 at the age of 83. His January 1923 article is the first to describe the use of mandibular advancement appliance for the treatment of lingual relapse secondary to craniofacial abnormalities. It is most likely that the device was made of vulcanite, a material developed in the 1830s and used widely for denture fabrication from about 1860 to 1930. Those of us my age have actually seen vulcanite dentures in use. Dr. Robin was absolute in his belief that this glossoptosis led to severe constitutional problems which allowed susceptibility to such diseases as whooping cough, appendicitis, and could negatively impact the continuation of mankind as we know it. This was a second article in the same year. And this is how oral appliance therapy for significant breathing disorders began. However, because the pioneer articles are not widely available for retrieval, it has often been cited incorrectly. We have invited noted Minneapolis actor Bob Davis, a veteran of over 70 productions at the prestigious Guthrie Theater, to read the paper that Dr. Robin presented to the French Academy in 1923. This paper was instrumental in the inception of dental sleep medicine, and I'd like to ask you to help me welcome Mr. Davis to the podium. Thank you.
Thank you, Doctor. Thank you. Thank you very much. Imagine, if you will, that it is not a beautiful spring day in Minneapolis, but it is a cold, cold January day in Paris. January 2nd, 1923, and we are at the Academy of Medicine. Messieurs Behol and Jauvert are presiding. You are the leading medical practitioners of France. And I am Dr. Pierre Robin. Merci, merci, merci. C'est vrai. With your kind permission, I proudly present my paper, Relapse of the Base of the Tongue, considered as a new cause for nasopharyngeal respiratory problems. To begin. To the numerous intrinsic ailments of the cavities of the nose and pharynx which hinder purely nasal respiration, we must add a new one. And I venture to call the attention of the Academy to this cause of obstruction which has not been heretofore studied. This obstruction, which is located in the buccal pharynx, is due to the relapse of the base of the tongue, which, while shortening the buccal pharynx, at the same time presses on the epiglottis and closes the superior opening of the larynx. This obstruction of the buccal pharynx by the ptosis of the tongue, let us call it, shall we, glossoptosis. Moreover, disappears immediately as soon as the subject extends his lower jaw to the front and keeps his lips open. This position, normal in all those who are mouth breathers, increases the oral cavity and permits the tongue to move both up and forward, a movement which unblocks the buccal pharynx and at the same time raises the epiglottis. We must, I think, attribute the previous lack of study of this problem, despite its widespread nature, to the fact that glossoptosis is always the result of an atresial dysmorphism of the lower jaw. And on examining the pharynx and larynx, one never notices any abnormality in that location. Glossoptosis is characterized clinically by difficulty breathing, a narrower than normal lower mandible, a receding chin, making a distinction in diagnosis between glossoptosis and nasopharyngeal respiratory obstruction easy. The authors and I myself have believed until now that mouth breathing compensated only for nasopharyngeal respiratory insufficiencies and did not understand why, in children, the removal of the adenoids did not always successfully reestablish solely nasal respiration, even when the nasal cavities were entirely free of abnormality. It is now a known fact that glossoptosis can be added as one of the frequent causes of respiratory tract obstruction. Consequently, buccal respiration due to glossoptosis will bring about multiple nasal and cavum complications resulting from the deficient functioning of these cavities and the consequent effects on neighboring organs. Based on the experiment described above, which can, as I said, be performed on children as well as adults, essential glossoptosis can easily be suppressed by moving the chin forward, thereby advancing the entire floor of the mouth, the tongue, and the musculature which attaches to the lower jaw and hyoid bone. Using that observation as a starting point and knowing that mouth breathers are always more likely to suffer from tuberculosis, chronic enteritis, and appendicitis, in order to make this position a lasting one and to increase the distance which separates the lower corners of the mandible, one need only have children wear a series of appliances, true intrabuccal supports, similar to those which I'm presenting, built by the specialist to meet the specific needs of each patient. These appliances can be put in place starting at age 3 and continuing to adulthood, and they allow the determination through functional adaptation of the skeletal correction and of the dental arches, satisfying thereby both facial aesthetics and the psychological conditions of psychic and organic life. In adults, correction is obtained immediately through the use of a suitable prosthesis. I have already had the honor of providing the Academy some of the work with models and supporting photographs related to the craniofacial modifications which I have obtained using my methods of treatment just as effectively in children 3 and 4 years old, in adolescents, in young adults, as it was in adults, as the attached documents allow you to verify. But at that time, I had not yet grasped and analyzed the true functional mechanism of the clearing of the respiratory tract through the release of the buccal pharynx and the opening up of the larynx, when I was carrying out the advancement of the maxillary joint in order to correct receding chins. It is in order to fill this gap, to underline the importance of not allowing ptosis of the tongue to persist, that I am submitting this work to the Academy today. I thank you for your kind attention. Merci beaucoup.